All right, Tom, we're here in the Canary Islands, 4th annual Trending Topics in GU Cancers. You're giving a talk about your big idea. Tell us about your big idea.
So we've come up with a Uromigos score. Essentially what we've done is we've looked at individual treatments and we've asked 20 experts around the world to score between 0 and 3, 0 being inappropriate, 3 being the standard of care, 2 an option, and then alternative, and then 1 unattractive, but and we asked the question to 18 experts around the world. We got a median score. Thanks to all those people who took part.
Yeah.
Came up with it on Wednesday night. They scored it all over the last 48 hours. Really exciting, well, brilliant, and I'm so grateful to them all. And one of the areas we looked at was in patients whose cancers has progressed after enfortumab vedotin and pembrolizumab.
After EVP, which was a 3, which was the standard of care. So now we're assuming everybody gets that. They progress, or if and when they progress. What is the standard? What'd you come up with?
Well, the level of evidence is weak. It's level 4. It's expert opinion. So there's no 1A. There's no kind of randomized trial. There's no big presentation. But this is where expert opinion is important because we're faced with the problem every day. What do we do? And the highest score, or the 2 that caused the highest score, which I thought was interesting. The highest score was platinum-based chemotherapy.
Yeah.
And in patients who were biomarker negative.
Yes.
So if you're FGFR negative and HER2 negative, chemotherapy clearly the standard of care, and that's scoring up in the high 2.8s, like high blood. Now that because of anything else. And then the second issue then is if you're biomarker positive, all bets are off. Yeah. And then chemotherapy comes down to a 2, and then other approaches such as erdafitinib and TDXD are getting similar type scores. Actually, oddly, TDXD got a higher mark than erdafitinib, which I thought was slightly odd. If you're FGFR positive, you're still getting...
Why do you think that is? I mean, there's clearly less data.
It may be the halo effect around ADCs. I think we've been using AD... I don't know what that is, but the reality is they're all in the 2s. Yeah. And many people, the experts, and thanks to the amazing job who did that, many wrote to me and said, look, Tom, these are really difficult questions. Right. But I think they're difficult questions, but that's okay.
But that's what you face in clinic.
That's right. Yes. And so and that's why they're all coming in those 2 type areas. We asked about sacituzumab govitecan as well, and that scored less than 1, so 0.5, and that's basically a void. And I think that's because the EMA had its label removed. Again, there's no evidence for it, and the drug, I think, has activity, but with a big negative trial and with a toxicity signal, not giving it makes sense. And then the last one was around what would you do if around re-challenging patients after immune therapy with EVP. So if you've had adjuvant immune therapy and for a year, would you re-challenge with enfortumab vedotin? So re-challenging with immune therapy, and that scored a 2. And you don't love that, I can see.
I don't love it.
But we can do a podcast on it.
Yeah,
I think we ought to do that. So I think I hope we're going to see more data in it, but in reality, prospective data post-EVP is going to take 2 or 3 years to generate. So this is probably the best we're going to do for the time being. And at the moment, there isn't a clear consensus. Platinum-based chemotherapy or biomarker-driven approaches in those with that, and not giving sacituzumab govitecan seems to be where we got to.
And perhaps this kind of score is most useful in this setting where there isn't data.
Maybe.
Right, in some ways, right?
Yeah.
So
Yeah,
anyway, very interesting.